Thank you, Dr. GURUPRASAD, for accepting to talk on pneumatic retinopexy.
Thank you, Dr. Murli, for that very generous introduction. And thank you for this opportunity in this big platform, the All India Ophthalmic Society, to be speaking to you all on pneumatic retinopexy, an important topic. Most of my videos are from Dr. Rajiv Muni's collection. So today's scenario, we have pneumatic retinopexy used in about 15% of all retinal detachments, most commonly employed modality for repair after pars-plana vitrectomy, alone or in combination with scleral buckling. So the principle of pneumatic retinopexy is very well depicted in the schematic. Gas is injected into the vitreous cavity in a certain volume, and because of the buoyancy and surface tension of the gas, there is an opposition of the gas of the retina to the underlying RPE, which results in reattachment. And this is further reinforced and made permanent by inducing inflammation by use of either cryopexy, as it is shown in this video. This is actually a chandelier-assisted scleral buckling in progress, but I have just shown it to as a representative video. And laser is another option, which can be done usually when in very shallow detachments by indentation, and after reattachment, which usually happens anytime between 1 and 4 days after the injection of gas. And the problem with laser is that we have to probably wait for some time, and not only that, we have to move the bubble away by a certain positioning of the eye, maybe a hyperextension or a lateral movement of the eye or the head, in order to move the bubble away in order to do laser. So the ideal candidate for pneumatic retinopexy is the phakic patient with a single break or multiple smaller breaks spanning no more than 1 clock hour. The superior 8 clock hours to the fundus is the area where we can do pneumatic retinopexy when the breaks are in these 8 clock hours. Or when there is, and it also necessitates that there should be clear ocular media, and that should be only when the identification of and treatment of the breaks is possible can pneumatic retinopexy actually be done. And the patient's overall physical and cognitive health is very important, because he has to maintain a certain position after the injection in order to cause opposition of the break to the underlying RPE. So marking an arrow to depict the direction of the head positioning is something that has to be practiced, because the patient has to know which direction he needs to actually lie down or sit with the gas bubble at the point where it opposes to the RPE with the break with the RPE. The other indications for pneumatic retinopexy would be probably recurrent RD after scleral buckling or VR surgery. Wherever scleral buckling is not possible, for example, in a congenital scarring case, which can be after a previous bleb or a thin sclera, or due to scleritis, or due to traumatic scleral tear repair in the past, or a squint surgery in the past. Some of the contraindications would be an inferior break, although success has been reported in the literature in a few cases. The gas bubble actually may not cover the inferior retina with standard positioning, and it is difficult to tolerate the inverted neck hyperextension or hyperflexion that is shown in these two pictures, which is extremely impracticable and not physiological and may be harmful to the patient, and especially if the patient is suffering from physical or other disabilities. The other contraindication would be advanced glaucoma, where gas injection can cause loss of the remaining visual field that is present in the patient. IDO monitoring for disc pulsation is very, very important in the immediate post-injection period, not only immediate, but for the next 48 hours from time to time, maybe every 2 hours, because the gas is an expandable gas. Proliferative vitreoretinopathy is another contraindication. So if there is pre-existing PVR, especially if there is a break near the traction area, one cannot do pneumatic retinopexy, though that becomes a contraindication, absolute contraindication in that. And the lens status, if it is an aphakia or a subluxated lens, then we cannot perform successfully pneumatic retinopexy because the bubble can migrate into the anterior chamber with loss of volume in the posterior segment where it is actually required. So there is a poor tamponade of the retinal break, and therefore the procedure may not be successful. Lattice degeneration, I would say, if it is extensive, and especially if there is a bullous detachment with lattice degeneration, the opening of unseen occult breaks or new breaks forming within the lattice degeneration by the displaced SRF. With the shear pressure of the SRF in a hitherto attached lattice degeneration, if the SRF migrates, it can open up small breaks causing a recurrence and a failure of pneumatic retinopexy. Air travel, if it is imminent, is another contraindication. For obvious reasons, we know that gas will expand when the atmospheric pressure is low. And elective procedure under GA, for example, especially if nitrous oxide is used in the next 2 weeks, if SF6 is used, and 4 to 6 weeks if C3F8 is used, is a contraindication because, again, nitrous oxide will enter the gas bubble and cause expansion. So technique, first step is to do laser photocoagulation and cryopexy to the breaks in the attached retina. So this is very important. Maybe it can be done a couple of days before the actual procedure of pneumatic retinopexy. And the 3 important steps are local anesthesia, infiltration of the subconjunctival into the subconjunctival area where you want to do the cryopexy, a paracentesis, a liberal paracentesis at that, because we have to evacuate as much fluid as possible in order to accommodate a large bubble in the vitreous cavity and inject the gas. It could be SF6 or C3F8. Of course, we have to take all aseptic precautions and do this in the operation theater. The volume of fluid removed by paracentesis plus 0.3 ml of gas. This is the formula for the volume of gas that can be injected into the vitreous cavity. This is for SF6. If you can remove 0.4 ml of fluid by paracentesis, you can inject 0.4 plus 0.3, that is 0.7 ml of SF6. That would be the calculation. So choice of gas will depend on the duration required of extended tamponade, that is usually SF6 lasts for 12 days and C3F8 for 38 days. So depending on what case may demand, what the case may demand, we can use that particular gas. Coming to the technique, injection is usually done in an area where the gas bubble is not likely to go into fish eggs, that is usually in the superior quadrant. The needle is withdrawn so that only the tip is inside. This is easier said than done, and the gas is injected into the small gas bubble that is injected first. So if fish eggs do occur, then light strokes on the sclera with a cotton-tipped applicator may be done to break the surface tension of the bubbles, facilitating the coalescence of the fish eggs. And if it goes subretinally, as it is shown in this, scleral indentation can be done to get the gas bubbles to coalesce and come back into the vitreous cavity. This again is a little blind procedure, but it can be done. This is the case of a macula on detachment with good visual acuity. Patient came with a loss of field of vision. So what can happen with gas injection is that the SRF can get displaced under the macula, and if the macula gets detached, it can lead to lifelong metamorphopsia. So we have to get the SRF back into the vitreous cavity, which is possible by injection and prone positioning, by which by about 2 to 3 hours, it is possible to get some of the fluid back into the vitreous cavity, and then the patient is then made to go back to erect position in about 2 to 3 hours in a phased manner, so that this is known as the steamroller technique, so that macular detachment does not occur. Sorry. So dealing with gas migration into the AC, this is only when monitoring the retina is not affected, otherwise you need not really bother. You can always top up the vitreous cavity with more gas. And if the new break occurs, I think we'll skip this because I think I've overshot the time. Dealing with SRF is something, if it is something like the picture on the left, I think you need not really bother, can be left and watch for resolution. But if it is at the macula, then you have to probably inject gas and wait for it to get displaced from there But what happens here is that once it is displaced, there is stretching. You can see that stretch, that double vascular lines that you can see there, and you can see that very well on autofluorescence. And this is probably what is explained, what explains the metamorphopsia that most of the patients of detachment, of retinal detachment experience almost for a lifetime. So the advantages, so I'm not going to the details. We also already know that it's a very elegant office-based procedure with judicious case selection. It offers distinct advantages over stale buckling and vitrectomy. The disadvantages are that there is a lack of generalizability to all the cases of RRD. The expanded criteria, so large retinal breaks as well as several smaller retinal breaks cumulatively spanning multiple clock hours of the retinal arc is something that have been tried in the recent past. Sequential alternation of head positioning may be required, but there is a need to repeat gas top-up in these cases. So in conclusion, pneumatic retinopexy is a safe, low-cost, well-tolerated, office-based procedure that is mostly underutilized. It is, in fact, we should try it in all cases wherever it is possible. Successful outcome is primarily dependent on a thorough retinal examination. So we have to make a proper drawing. The media has to be clear. We have to identify all the breaks, and definitely the results will depend on careful patient selection and can be a first line of treatment. Thank you very much.
Thank you, GURUPRASAD. Wonderful presentation of all the aspects of pneumatic retinopexy, especially with very good animated videos. I have one question to all the panelists. How many of you are still using pneumatic retinopexy as one of the modalities in your practice? Starting from Naresh, are you using?
Yeah, I'm definitely using.
You are using. What percentage of your patients would you use? Like?
I think less than 1 to 2%.
So that means very, very rarely you do.
Yeah.
What about Hemant?
I too do very rarely.
Extremely rarely, but I would say the very useful in for me in a detachment where already have buccal, patient come with a like a recurrent RD, break lifted on the buccal, particularly if it is superior, or even sometime in vitrectomies I also, you have a break, already have a buccal, break lifted up. Those eyes, I mean, just a gas injection and everything settles down well, extremely.
Thank you. Kumar?
Yeah, I would agree with Pramod. Mostly as a secondary pneumatic retinopexy is more useful in our practice. But having said that, I will not assign any percentage to the number of cases that I do with this technique. If there is a case that fits all the criteria, whether he comes in on Monday or a Friday. Now I'm referring to this because in the US, the percentage rates of pneumatic retinopexy apparently goes up on Fridays, because they don't want to operate on Saturdays and Sundays because they want their weekend off. So I would definitely use it if the patient fits the bill.
No, I'm in your practice, there are many patients who will fit the bill, and in spite of it, we don't use it. That's
we must use, because in the light of the latest pivot study, which clearly shows that metamorphopsia, the ultimate visual acuity, everything is better in pneumatic retinopexy as compared to vitrectomy.
Yeah,
so there is clear proof that states so. So we must not be looking at economic criteria at all for our patients.
No. The point I am trying to bring a consensus here is that although pneumatic retinopexy has been around for more than 25 years, in fact, we learned the pneumatic retinopexy from the originator himself, Dr. Hilton, when he was in Bangalore for 3 months, and we did pneumatic retinopexy under his supervision. And in spite of the fact that we learned from the master himself, we rarely use it, except as Pramod said and probably Hemant said, as a secondary to a failed buccal or an open break causing a redetachment in a scleral buccal. We find that it works very well. GURUPRASAD, do you, how often do you use?
Just I wanted to make a point. The reason why we may not be able to use it, though we want to use it, is because many of our patients, when explained that there is a possibility that the initial reattachment rates are not as much as in a scleral buccal, they will say, sir, I want it done in one shot, please go ahead and do what is more fail-proof.
Yeah, I mean the reasons, that probably you are right. The reasons why we don't use it so often is because of its low success rate and the need for repeat surgery, which our patient population do not really find it, so nice.
I use it very often. Actually, I use it in about 8 to 10%. I would say this again is a arbitrary figure. I don't really know the percentage, but I use it very frequently. I want to give it a trial with pneumatic whenever possible, and that is one of the reasons why I do that is to reduce the cost to the patient. And if it succeeds, then why not use it? Why not?
Yeah, last comment
get
from
the
Ramesh, and we move on to the next speaker, Dr. Kumar. Your mic is not on.
I just wanted to know, when do you say that your pneumatic has failed? So is there a duration by which you expect the subretinal fluid to get absorbed? And when do you say it has got failed? That's my first question. And my second question is, do you ever do a repeat pneumatic retinopexy? In the sense that if you had tried putting SF6 as your gas as the first choice, and you feel that the gas has vanished, but still there is a residual subretinal fluid, do you end up doing injection C3F8 and add it up as a repeat procedure?
When I say successful pneumatic retinopexy,
Okay, please, yeah, please.
so I mean successful. By successful, I mean that the patient's retina is reattached in 3 days or 4 days, and that is the time by when I do the laser, or sometimes earlier than that by indentation I am able to do laser. But I do cryo most of the time. I've done laser very few times. But if it is not getting reattached in about 3 days, then I think it will not reattach later, because the volume of the gas gets less, and if the detachment volume, that the velocity or bullous nature of the detachment is remaining the same, then probably the gas bubble is not enough to tamponate the break, or there is some other pathology or attraction near the break that is preventing it from reattaching.
Would you do a repeat pneumatic in that case with a different gas tamponade?
I always use C3F8. I have never used SF6 because of the volume of SF6 that is required.
Yeah,
It's always more, and I'm not able to evacuate that much of fluid from the anterior chamber and make the eye soft enough to accommodate 0.6 or 0.7 cc of SF6. So I use C3F8.
Yeah.
I do top-ups when there is when I see success and I feel that extended tamponade is required for another week. Then I do top up the gas volume, maybe on the 5th day or the 6th day, just to be on the safer side.
Last comment from Pramod, and we go on to the next.
Yeah, basically what you look at it, whether a break is flattened or not. If break is flat, and you have adequate retinopexy around it, you can safely wait and watch. And if once the pigmentation start developing, which is somewhere happen between 9 and 11 days, we take as a roughly 2 weeks. So once break is sealed, and even if you have residual fluid, you are not worried about.
That's provided you have re-examined the retina once again and noted that there is no new break that has developed as a result of the migrating fluid.
Yeah.